Well, hello and good afternoon. My name is Santra Denis, and I'm the Executive Director of Miami Workers Center. Super excited to be with these phenomenal women, and I'm going to talk about something that is near and dear to my heart, a panel called Health Equity, Strategies to Address Inequities in Health Access and Outcomes in BIPOC Communities. So much is going on right now, and this panel is spot on for what we're experiencing today. We know that there's a COVID-19 pandemic that we're still dealing with right now. We know that Black and Brown BIPOC communities are not only experiencing COVID-19, but also dying as a result of COVID-19. We also know that access to testing and vaccination also mirrors these disparities as well. And so lots to talk about in this phenomenal panel. I'm going to pause and introduce our phenomenal panelists. We're going to start with Dr. Holder, who's a fellow in the American College of Physicians. She's dedicated her life to underserved populations and currently is at Florida International University, the College of Medicine. I went and got my master's at FIU in public health. So super excited to be here with you, Dr. Holder. And we're going to make the introduction just a little brief so that we can go right into the topic and give folks a little bit more time, for the Q&A. We're also going to go to, and if Dr. Holder, your name is there, so you don't have to wave. Dr. Bridges, Khiara Bridges is a professor of law at UC Berkeley. She does her work at the intersection of race, class, and reproductive rights. Come on down to the Miami Workers Center, Dr. Bridges, because that's what we're working on as well. We're super excited to have you here too and learn about your work as well. And Ms. Marriott, Nicole, super excited to have you as well. Ms. Marriott is the president and CEO of the Health Council of South Florida, and they've been doing amazing work, really being the source of unbiased health and quality information, data, and analysis in not only Dade County, but Monroe County as well. We're going to actually move into the panelists and their presentations. Their presentations will be about 12 minutes each, and then we'll go into a Q&A. And we're asking folks to go ahead and once you have questions, drop them in the chat, stay engaged so that we can get to you all at the end of these presentations. Thank you all so much. And we're going to start with Dr. Holder.
Hi, good evening, and thank you for having me and giving us a moment to just discuss the important topic. I was asked about what is health equity and what are we really talking about? We hear it all the time, equity. I hope my slides are working pretty well. It's kind of difficult in this system. Are you guys seeing it okay?
Yes, we are, Dr. Holder. Go ahead.
All right. And when we talk about equity and health disparities, I'll just give a little understanding. This term really started coming around in the 1990s, a little bit earlier. A lot of research was being done because we were seeing disparities, or we're seeing the differences between one group of people and another group of people. What was happening? Why are we seeing the differences? Now, health differences have always been around. We know, and I talk about my grandfather. My grandfather lived till almost 100 years old. He lived on a hill in a rural part of Jamaica. He had lots of exercise. He farmed his entire life. He ate well, never smoked, never drank, and he lived till 100, almost 100. But there are differences in our health, of course. There were differences in which he definitely had more arthritis and everything, which is age. That's really not what we're talking about, because we know there will always be differences in people based on genetics, based on other factors. But when we talk about equity and disparity, what we're really coming at is what are the factors that make people healthy? What are the things that helped my grandfather live till 100? And those are the things we call the social determinants of health. And when you look at the social determinants of health, it is where you live, where you work, where you grow, where you play, where you love, your access to money and power, and the policies under which your life is governed. So we know that when you see the slide that I'm showing of the social determinants of health, my grandfather's genes had something to do with his longevity. We knew physical environment, built-in exercise. He didn't have to pay YouFit or anybody else, but he had regular, challenging exercise that kept his cardiovascular health in check. His health behaviors, he ate well, his environment was clear, free of pollution, he never drank, never smoked. Socioeconomically, he could support himself, he had housing, he had support, he had a loving family. So when you look at all the factors that came to make my grandfather live so long, it was really quite clear. Now, when we look at health disparities, what we're saying now, considering the socioeconomic factors, considering your environment, what are things that put people at disadvantage? And that is what drives the disparity in the health. We know that you'll have different rates of things, but why is it that one group ends up with so much more disease than the other group? And when we look at some of the health, we know health, we just said it, it's about social factors. It's about how educated you are. It's about poverty. And when you look at Dade, Broward, Palm Beach County, you're looking at Black communities that are substantially impacted by poverty, substantially impacted by not being able to get the education that they need compared to the greater population, 77% versus 88% for the greater population. So we're looking at things that are driving your health outcomes. And then you look at diseases, and this is just overall in different parts of Florida, because we know that African-American communities have higher rates of diabetes, have higher rates of high blood pressure, has higher rates of obesity and heart attacks, and higher rates of HIV. Now, we just talked about what are the factors that drive this. So again, socioeconomic factors, access to healthcare, so many things that we don't get regularly. And so when we think about, and I'm missing a slide, let me go back. So when we think about coronavirus, which I think is the perfect process that can really capture what we've been talking about for the last 30 years about health disparities and health equity. Because when we talk about health equity, we are now saying that if we don't get committed to addressing the factors that affect your health, which is the socioeconomic factors, the policies, the environment, the ways you get clinical care, if we don't address those things and meet people where they need, we're not going to reduce these disparities. And think about it with coronavirus. Coronavirus came at all of us, and it went after populations that were greatly affected by previous years of disparities. We talk about it here. You look at these issues here with the disparities in the poorer communities. And I use Black community here, but the Hispanic community also doing worse than richer communities. And so coronavirus comes in, and the communities that are already weathered because of the socioeconomic factors under which they live and not having responses that supported their improvement in health, they were first to be hit and hit hard. And we know what the data shows, that the death rates for Blacks and Hispanics are much higher than richer people who happen to be white in our communities. And so when we look at the solutions to coronavirus, we saw, again, when we say equity, are we going to give communities what they need to be able to improve their health outcomes? So the coronavirus vaccine response, without that equity lens, demonstrates what we say when we didn't give the communities what they needed to be able to get everyone immunized. So elderly people, they were forced to have to try and navigate a computer system that they didn't have the skills. That wasn't giving them what they need to get immunized. Poorer people, there were no vaccine sites in the neighborhoods. They weren't able to also get transportation to get the vaccines. They weren't able to get to the Wi-Fi. They weren't able to stay online and do all the factors that's necessary to get the vaccines. So we saw that there were so many barriers, all those socioeconomic factors, those education factors that then blocked people's access to vaccines. Now we are trying in the back end to try and solve these issues and put that equity lens on to try to get the vaccine. But what coronavirus has shown us is that why is it so important that we need an equity lens to be able to combat these disparities? It's not about treating one group fair because all these were making up for lost time. When we use an equity lens and giving people what they need to achieve that health outcome that we talk about and be like my grandfather lived to 100, we benefit our entire community. Coronavirus, everyone, at least up to 70% of this population must either get vaccinated or have the infection to be able to take us back to the way closer to how we used to be. I'm hoping a better way than we used to be. So when we say we need everyone vaccinated, it's important that everyone gets the way that they need it so that can happen. Because if we don't get everyone vaccinated, we're going to get mutant strains like we're already seeing in Brazil and in South Africa. And then all the folks who ran to get the vaccine earlier because the systems allowed them to get the vaccines earlier, we're going to be right back where we started because those vaccines may not work. So this is so crucial why equity is important because it benefits all of us. And so if we're going to address healthcare disparities, we must use an equity lens where we give the communities what they need to be able to address the health and improve the health outcomes so we can all live long, happy, healthful lives. And unfortunately, coronavirus has shown us accelerated so many deaths because it magnified the underlying disparities that we have been experiencing for hundreds of years. And we can go into the policies and what drove us here, but the coronavirus experience shows why we must use an equity lens so that the entire community benefits, because it doesn't make sense to not get one group immunized and get another group immunized because that other group who's not immunized or not getting the benefits, that virus may mutate and then we're right back where we started. So we have to understand health disparities, socioeconomic factors. I'll close with this. There's a great researcher in the UK, Margaret Whitehead, who says that when we are talking about disparities and equity, it is about diseases that are avoidable and the differences that we see, these health differences that became because of avoidable conditions, unnecessary conditions, and unjust conditions. So we can make those changes by having a full understanding of what I show here. That we don't want this equal treatment. It's not equal because equal treatment might leave us with offense. And going between equitable where we have what people need, and then relieving and getting rid of all those barriers so we can all have a fair chance of being like my grandfather, who the society and every aspect of how he lived supported his longevity so he could live for 99 years in a pretty much barrier-free environment to be able to live his best life. Thank you.
Thank you so much, Dr. Holder. I think it's important to kind of like pull out just a few of the things that the issues that you address. When we're talking about disparities and why folks don't have access and what really are the barriers to that, we're talking about education, whether folks have access to education, what income they make, all of these things come into play. And thank you so much for sharing that amazing presentation. We're gonna move to Dr. Bridges. Can you please explain how implicit bias shows up in the medical field and what various sectors can do to address it?
Well, thank you so much for that prompt, and thanks everyone for being here and engaging with a really important panel, I should say. So the reality is that people of color are sicker and die earlier than their white counterparts, period, point blank. We have higher rates of every major common illness, including heart failure, hypertension, infant mortality, maternal mortality, diabetes, asthma, and I might even add COVID-19. And so where should we look when we are trying to explain these racial disparities in health? Now, the reality is that we should look in a lot of places. Unfortunately, most of the attention has landed on one place, on providers. Not on providers as bigots, as bad actors acting badly, but rather it has landed on providers as possessors of implicit biases that cause them to offer inferior healthcare to their patients of color. Indeed, the most popular theory of racism in healthcare today is the fact of implicit bias. However, there are significant limitations to the theory. So first, I'm going to describe the literature on implicit bias, and then I'll discuss some of its weaknesses. So in 2005, the Institute of Medicine, or IOM, released a report documenting that people of color receive lower quality healthcare than white people, even when one controls for insurance status, income, age, and severity of conditions. And by lower quality healthcare, the IOM meant that physicians were giving concrete inferior care to their Black patients. The IOM reported that Black people were less likely than white people to be given appropriate cardiac care, to receive kidney dialysis or transplants, and to receive the best treatments for stroke, cancer, and AIDS. And the IOM concluded their report by describing what they called a quote unquote uncomfortable reality. They said, quote, some people in the United States are more likely to die from cancer, heart disease, and diabetes simply because of their race or ethnicity, and not just because they lack access to health care. Many studies have buttressed the IOM's findings by documenting that providers are less likely to prescribe and deliver effective treatment to people of color when compared to their white counterparts, even when you control for all those things that might otherwise explain the disparity. In light of these studies, observers have argued that if people of color are sicker and die earlier than their white counterparts, if there are racial disparities in health, this may be because physicians have racial biases, and their biases may cause them to give their patients of color inferior health care, and in so doing, contribute to racial disparities in health. Now, most researchers thinking about the ways in which provider bias might contribute to racial disparities in health have looked to providers' implicit biases. And the idea is that providers have views about racial minorities of which they are not consciously aware, but these views nevertheless lead them to make unintentional and ultimately harmful judgments about the care that they give people of color. Many of you likely are familiar with the implicit association test, and this is a test that purports to measure test takers' implicit biases by asking them to link images of Black and white faces with pleasant and unpleasant words under very intense time constraints. Now, when physicians are given the IAT, they tend to associate white faces and pleasant words more easily than Black faces and pleasant words. In fact, research shows that these pro-white, anti-Black implicit biases are as prevalent among providers as they are among the general population, which is to say, there is nothing about medical school that cleanses folks of the biases that people in the general population have. Further, there is research that purports to show that providers' implicit bias impact the healthcare that they give. So it's not just that these tests are sort of documented that they have them, but when sort of experiments are run, folks, we can link up pro-white, anti-Black implicit biases to judgments that physicians are giving about the care that they want to provide to their patients. They're giving inferior care to their patients of color and superior care to their white patients. So when medical schools and residency programs attempt to address racism in healthcare, this is the focus that they tend to have. The focus is on implicit bias. And programs tend to educate students and residents about implicit biases, and some of them may even give their students an IAT so that the students know that they have implicit biases and the extent of them. And then these programs tell their students to go out there and be mindful about how their documented implicit biases may influence the healthcare that they give. Now, all of that is laudable, but my issue with theorizing racial disparities in health totally in terms of implicit bias, my issue in explaining racial disparities in health totally in terms of implicit bias is that it is insufficient. That is, the fact that providers have implicit biases is an incomplete explanation of racial disparities in health. Implicit biases have to be put in conversation with structural and institutional racism. And so in the balance of my remarks, I will discuss briefly the analytical limitations of the field of implicit bias, and then I will ask the question, what does a theory of racial disparities in health, what does an explanation of racial disparities in health look like when we put implicit biases in conversation with institutional and structural racism? So to begin, the field of implicit bias is limited on its own terms. The field is focused on the individual and the prejudices and aversions that they may or may not possess. And note how this focus is a piece with traditional understandings of racism, limited understandings of racism that understand racism as nothing but bigotry, right? Understandings of racism that posit that racism is what happens when racist individuals think racist thoughts and then do racist things. Progressive theorists of race and racial inequality have fought tooth and nail to challenge that very narrow formulation of racism. We posit instead that in the post-civil rights era, racism is better and also defined as what happens when institutions and structures operate in a race-neutral manner that nevertheless perpetuates historical racial disadvantage and produces new forms of racial disenfranchisement. Nevertheless, implicit bias remains squarely in an individual-centered paradigm. And this is a framework that causes us to think of racism as a private concern, which mitigates any responsibility that the state, society more generally, that the state has for eradication of racism and racial inequality. And so we might be critical slightly of implicit bias research because it might commit the error that non-critical thinkers of race make. It might focus on individualist racism while ignoring institutional and structural racism. We might be focused on providers' implicit biases while ignoring the two-tiered healthcare system within which they operate. We might be focused on figuring out whether providers can match a white face to a positive word faster than they can match a black face to that same word while ignoring the social determinants of health. Further, there's an argument to be made that the problem is not that individual providers have implicit biases. Instead, the problem is that we have constructed a society wherein people of color are at the bottom of most measures of social well-being. People of color are more indigent than white people. They are incarcerated more than white people. They are unemployed more than white people. They are detained in immigrant detention camps more than white people. They rely on the social safety net more than white people. They die violent deaths more than white people. They are sicker than white people, and they die earlier than white people. And it is doubtful that implicit biases alone can explain those disturbing inequalities. More likely, the reverse is true. Those inequalities explain implicit bias. And it's for that reason that progressive race scholars have argued that the best approach to dealing with implicit biases is through a sustained process of cultural change, which results in the elimination of the socially disfavored status of a subordinated group. Simply put, if people of color were not invariably at the bottom of social hierarchies, providers likely will not have negative implicit biases about them. Now, most advocates of implicit bias as a theory of racism in healthcare would agree that the problem lies less with the existence of implicit bias and more with the existence of racial stratification. They would think that the whole point of their documenting the prevalence of implicit biases and the behavioral consequences that flow from them is to undo existing racial hierarchies. So, for example, if we prove that some significant portion of obstetric providers have pro-white or anti-Black implicit biases, we might be able to link the fact of implicit biases to racial disparities in maternal mortality and morbidity. However, the problem is that the focus on implicit bias has become all-consuming. It has cannibalized all of our attention to all of the other things that we know make people sicker and die earlier, like social determinants of health, right? The focus on implicit bias has caused us, I believe, to lose sight of our goals. We have come to believe that the elimination of implicit biases, as opposed to the alleviation of substantive inequalities, is what we are fighting for. We have come to believe that the goal is, for example, to rid obstetric providers of their implicit biases, as opposed to eliminating racial disparities in maternal mortality. But most importantly, and I'm going to stop here, the field of implicit bias has to be put in conversation with structural racism To be precise, individuals with implicit biases as well as individuals without implicit biases are practicing medicine within the two-tiered healthcare system. And this is a system that allows for the privately insured to access healthcare that is simply better than the publicly insured, not to mention the uninsured. And also, we have been focusing on implicit bias while ignoring what Dr. Holder already told us, the social determinants of health, the environments in which people of color are living, working, aging, playing, loving, etc. They're unhealthy. And so we should not be surprised at all that people of color are sicker and dying earlier than our white counterparts. And I think that we're missing our focus is misguided when we're focusing solely on implicit bias to the exclusion of all these other things. And I'll stop there. So Santra, you're muted. Oh, still can't hear you. Okay, Santra, so maybe we should turn it over to Ms. Mary. Okay, so,
Okay. So Nicole, Nicole, you're on next.
Okay. So a wonderful evening to all, and thank you, Santra, for the warm introduction earlier on, Adele and Catalyst Miami for providing me an opportunity to speak today a little bit about what the Health Council does in the area of health equity and community health workers. And so we as an organization, we're one of 11 health planning agencies that are located across the state of Florida. One of the things that we provide is the collection of health data for hospitals and nursing homes within our community. We provide this information to ACA on a quarterly basis. And basically for our service area, which includes Miami-Dade County of over 2.7 million residences, any new facility that is trying to open service here in Miami-Dade County must demonstrate that there is a need and go through a process called CON, Certificate of Need. And so we believe that the contribution that we're making to our community in terms of making sure there's equitable services for expansion of services and new services in our community when they're utilizing this, when they're utilizing this process, we're able to impact that the services are going where they're needed. So let's talk a little bit more about what we've been listening to today in terms of how we can really try to impact health equity in our community. Of course, Miami-Dade County is known and celebrated for its great diversity. We're uniquely called one of those minority-majority communities where the majority of our population identify as a minority group. Over 71.15% of our population here in Miami-Dade County identifies as Hispanic, while 28.49% identifies as non-Hispanic. Of that group, 16.42% of those are Black or African American. So we know that achieving health equity for a community as diverse as Miami-Dade County is not going to be an easy task, but it is definitely attainable. And so how can we do this? We believe that working with community health workers and integrating them as part of the care team is one of the solutions in which we can address some of these health inequities that many communities are facing. Community health workers are usually lay workers that work in the community either for pay or as a volunteer. And many community health workers are based either in a community health setting or social services. They are trained in cultural competency, health literacy, case management, and basic public health. And so these health workers, community health workers, and they're known by many other names. You may know them as community health advisors, lay workers, patient advocates, outreach workers, peer health educators, or health representative amongst their many titles. But they serve as that frontline worker who really have that tie to the community and are able to better navigate and help those underserved community connect with the care that they need. Their role as this frontline worker is really predicated on their deep roots in the community as being trusted residents, because many community workers are really exactly from the communities that they are serving. Their approach to service and helping is really a grassroots approach. And for many communities, this is an approach that really works to bridge that gap between those communities who are less connected or low income to be able to access service. And so by incorporating the community health worker as part of the care team, we do see this as a proven strategy for timely intervention to help reduce long-term collective trauma and help to build resilient communities. So what makes community health workers so successful with working with the community? It's their ability to really be creative and innovative in their approach. As I've mentioned before, many are working in very underserved or low-income communities. And usually for many of these communities, let's face it, they are either Black or Brown residents. And so there's a lot of challenges, and Dr. Holder and Dr. Bridges have talked about some of those challenges that many of these communities are facing. It goes beyond just health. There's a lot of issues from a social and economic standpoint that are impacting many of these communities. If the focus really is to keep the lights on or to put food on the table, do we really believe that accessing the doctor is going to be top of mind for many of these households? So the idea that community health workers can really help to bridge that gap, especially outside of the formal health setting, goes to show the level of how we can really impact the care that our communities of colors can face. And so these community workers who are acting as advocates for social services, they do understand the importance of being able to bridge that social gap that these families are facing. That will help to bring around the health impacts we're trying to look at. Because if you can solve many of these social issues, you'll have better outcomes when it comes to taking care of their health. One of the things that we also recognize with community health workers and their importance in our community is the fact that they speak the same language. They understand the cultural barriers that many of these families may be facing. Again, allowing for that mediation between what that formal provider setting may provide. And when Dr. Bridges talks about implicit bias, and providers may be not necessarily realizing that they're not providing the same level of care because they may not look like the person that they themselves represent, the community health workers might be able to help better with communication, with being able to interpret better, and also help that patient to understand what some of these providers are also trying to relay, which are valuable health messages. So we see the importance of integrating the community health worker in the process. Today in the state of Florida, community health workers are a much more respected and important role thanks to the Florida CHW Coalition. They have been working tirelessly on behalf of this profession. CHWs who are receiving their certification are being able to be paid better. As I mentioned, many are volunteers. Becoming certified allows them to be able to hold better jobs. And this is something that is important because, again, coming from many of the communities that CHWs are coming from, they need to also be a part of the work team and being paid and recognized for the important work that they're doing. This coalition, which was founded in 2011, again, it's been mostly volunteer focused and driven, but they've been promoting CHWs, providing training, and they're over 700 members strong throughout the state of Florida, with at least a third of those members being certified. Now, much of the CHWs, although they're located across the state, many are concentrated in the Southeast region, which covers Miami-Dade County, Monroe, Broward, and West Palm Beach. Since its inception, the Health Council has really worked very closely with the Florida CHW Coalition. We've provided platforms for speakers to come in through the Southeast Regional Symposium, to provide training, to provide exchanges for best practices, and really just provide a platform for CHWs to network. Earlier this year, we held some virtual focus groups, in-person groups. Earlier last year, before COVID, we were able to do those in-person meetings and really talk to CHWs about some of the things that they believe are important in their job, how we can help to facilitate it to make it easier and better, allowing the Florida CHW Coalition to now work on developing other training materials, because the goal is always to make CHWs better and stronger in their role in the community. And so as part of what we're seeing right now in our community with COVID-19, which is affecting our community, we do see the CHWs being a very effective part of leading the fight against COVID-19. We know, and we've talked about it exhaustively, that communities of colors are being disproportionately touched by COVID-19. And by using CHWs to cut through some of the misinformation, to connect individuals to services, and really understand and help people navigate what is going on, we believe that this could be the key in helping to accelerate testing, to help to make sure that minorities are receiving vaccination. Because as Dr. Holder has mentioned, you can't just vaccinate one group and not give vaccination to another group and expect that we're going to get back to some level of normalcy. So we want to make sure that all communities are being connected, and CHWs can be the driver behind this. What's interesting is on May 6, 2020, Health Affairs published a blog by Denis Smith and Ashley Wennerstrom titled, "To Strengthen the Public Health Response to COVID-19, We Need Community Health Workers." In the article, they mentioned that on March 19, 2020, Department of Homeland Security, Cybersecurity and Infrastructure Security Agency issued a memorandum identifying essential worker during the pandemic and listing CHWs as being essential and critical infrastructure workers who are imperative to the response of COVID-19 as both a public health and safety crisis for our community. Again, as these trusted members of our community, CHWs are very valuable in serving as the eyes and ears and lifeline and being culturally competent to link in vulnerable population to care. Looking at some of the things that CHWs can do, especially during this COVID-19 pandemic in our community, as we talk about the fear of accessing services, CHWs can assist with clarifying to communities of colors how some of these services can be accessed and where it can be accessed. When we look at the fear of accessing services, sometimes it's from an immigration standpoint. We talk about the diversity of our community. Again, CHWs can make sure that they're connecting people to safe spaces, to the right places, and so they're able to access care without the fear of retaliation because of their immigration status. Right now, we know that many communities of colors are completely underinsured. So there's a lot of self-medication, self-diagnosis going on. Again, community health workers can help cut through that. They can help to link to care, help individuals to apply for services. Lack of health information and health literacy. CHWs can be that driving force, again, to be able to be that effective communication barrier and lifting those barriers for communities. And I could go on and on about the different things that CHWs can do, but I think overall you get the point that if we're going to strive for health equity, we have to have a linkage to our vulnerable population, and we believe CHWs can be that driving force in that linkage. So in closing, I do want to emphasize that we at the Health Council of South Florida, we strongly believe that health equity and access are fundamental to eliminating health disparities. Human capital is just as important as putting resources within our community and make it a level playing field for many at-risk communities and population. And again, I cannot emphasize enough that CHW can be that key driver in connecting and building those bridges to a healthy community and for our residents. So in closing, I echo all of what we've heard tonight from Dr. Bridges and Dr. Holder as we talk about how can we make sure we understand what is going on in our communities of colors and really try to make sure that we bring about a system that provides better access to health for all. And we are no longer just talking about one community over the other, but it's for all. So thank you.
Still no mic with Santra. I know that we were supposed to follow up again in looking at solutions. And I wanted to mention, you brought up very well about community health workers and the uninsured and underinsured. And in South Florida, we have a large number of uninsured. And one thing that Florida did not do was expand Medicaid. And that has been a huge impact on the health. You saw the data that I showed on the obesity, diabetes, because of all the long-term poverty and racism, as Dr. Bridges pointed out so clearly, that we need access to health care. And so the community health workers should be within a system, but the patients need to get health care. And the Affordable Care Act being expanded would have guaranteed poor people, whether through Medicaid or through some way of subsidizing the health, would have gotten health care. And again, I bring it back to coronavirus. One of the first instructions that we heard in coronavirus was call your doctor. Now, when you have a large percentage of the community that didn't have a doctor to call, so when they showed up at the emergency room, they were often sent home, or they weren't evaluated correctly because of the biases, and that led to unnecessary deaths. There's a medication that's out right now, monoclonal antibodies, that's given to people who are early in the disease process of coronavirus, not when you're sick that you have to be hospitalized. But how do you know how early you are? And then how do you know where to go? And when we look at the distribution of where this monoclonal antibodies are in South Florida, we already know what hospitals have it, the richer hospitals.
Can I check in to see if, can folks hear me?
Yes, it's working.
Great. Continue, Dr. Holder.
So that whole disparity in care and delivery of services take right down to who gets treated early for coronavirus so they don't end up on a ventilator. And again, it's the richer people, it's in the white neighborhoods that have access to that. But if you don't even have a doctor to help you navigate and a trusted messenger, so now the vaccines are here, you don't really trust that messenger that's been seeing you in the ER and urgent care. And it is so crucial that the entire country gets immunized or have no transmission so the entire country can go back to some sort of life and the whole world. So now this whole disparity and the racism and all the unjust treatment that poor people have had now comes back to hit us and say, if we don't do it for all of us, we're not going to make this through. So this is where we now need healthcare for all. We really do if we're going to get through this coronavirus. So this is not going away. And then the next onslaught. So the community health workers have a huge role to play, but actually having healthcare has a huge role to play. And racism, where we doesn't become an afterthought. So we don't get these pop-up spots in churches after you've outlaid a system that forgot about us, and forgot about the poor people and was not equitable because it didn't meet people's needs and in the end will hurt us all. So everything that we've been talking about really comes together so beautifully. Santra, you're back. Great.
Thank you all so much for your patience. Technology often fails us, but y'all are amazing. So I just took a few notes and I want to do a quick recap and then go into some questions. Dr. Holder, you really talked about social determinants of health, housing, food, jobs. If folks do not have healthy access to these things, of course, we're going to see high rates of diseases, right? You can't not have money. You can't not have good work. You can't not have access to great resources and expect for folks to be healthy or show up healthy. Dr. Bridges took it one step further, you know, more than implicit bias with individuals or with physicians and practitioners, we need to be thinking about structural racism and institutional racism and how that too allows for these disparities that we see. And then for sure, I wanted to say to Nicole, Ms. Marriott, that not only do we need community health workers because they serve as trusted messengers, right? When folks see our people that come from their community who eat the same food that they eat, that have been through the same experiences as them, they can trust them more. But not only do we need them, we need that these systems pay them well to make sure that they have benefits so that they too don't suffer from the same disparities that we're talking about. And we're definitely talking to our elected officials, all the folks with money that, you know, we don't only want folks in our communities to have jobs, we want good jobs with benefits so that they don't have to experience for them and their families disparities as well, excuse me. A good friend of mine, Natalie, in the chat box had a question. I believe this was to you, Dr. Bridges. Are there any examples of implicit bias training that integrates social determinants of health that you know of?
Yeah, so that's a great question. I have I've been doing this roadshow where I have been talking to obstetrics and gynecology departments at their grand rounds, and they've been bringing me in. And the prompt for my invitation has always been implicit bias, right? So they want me to come and talk to them about implicit bias and how they can do better. And before I leave, I let them know that the conversation can't stop at implicit bias. We need to start thinking about what medical schools, what OBGYN departments can do outside of their departments, right? We need to start thinking about how OBGYN departments and medical schools and, you know, schools for healthcare providers generally can engage with their patients before the clinical encounter. Because a lot of times the clinical encounter comes at the end of a whole bunch of disenfranchisement, right? And there's only so much you can do at the clinical encounter. What you can't do oftentimes is erase, right, the decades of marginalization, right? The decades of having lived in a food desert, the decades of having lived close to a highway with poor air quality and, you know, poor water quality, right? A lot of times the clinical encounter is really just, again, just trying to triage as opposed to if our focus was elsewhere, right, we would be making more large-scale transformations. So have I seen implicit bias trainings that incorporate social determinants of health? I'm working on it, right? I'm sure there are some that are out there, but when, you know, my intervention is to encourage you know, all of the institutions that I come into contact with to think bigger than the clinical encounter, bigger than the physician-patient relationship, and think about how to reach patients and how to help, you know, would-be patients before they even end up in the space asking for healthcare.
Thank you so much, Dr. Bridges. I think that really speaks to, you don't see these disparities at this rate if it was just the providers, right? If it was just doctors, right? And so I think we have to begin to dig deeper to see what other systems are involved in the disparities that we're seeing. Ms. Marriott, this is to you. And I want to kind of preface this question by saying, I work with we organize domestic workers at Miami Workers Center, folks who serve as healthcare aides, home health aides, excuse me. They are house cleaners, nannies, no paid time off, no sick days, none of that, no benefits. And so the question asks, are there other components such as access to health, cultural, competent, and quality care that should also be coupled with community health workers? And so again, I'll ask the question as it was written. While working with community health workers is one component of addressing health equity, can you speak about other components such as access to health, culturally competent and quality care, et cetera, more than the systemic issues that must be addressed to achieve health? And that's from one of the questions in the chat. And Nicole, I think that is to you, but I think any other panelists can take that as well.
Sure. So I'll start off, and I'm sure the other panelists can add to that as well. So to that point, absolutely. With community health workers, that is just really one of the ways in which we think we can bring about health equity, because we're looking at the fact that we have a group who can really understand, you know, the struggle, as you've mentioned very eloquently, the struggles of the communities, because they're from those communities themselves. So, but beyond that, it's going to take so many other facets of our community to be a part of this. Again, going back to providers, that's a big part of who needs to be at the table. And I think one of the things that, as a community, that I'm very proud of what I see in Miami-Dade County, and again, before pre-COVID, when you would go to meetings, you would see all the different players at the table trying to have that impact in making sure that we're addressing all the different layers of dealing with health issues within our community. The Miami-Dade Health Department has a group arm called the Consortium for a Healthier Miami-Dade, and they have 7 different work groups within that setting. They touch on the elderly, they talk about the health and built environment, they talk about disease prevention, because it's not just dealing with the health component, but it's our social environment that you have to also look at the economics of our community and really try to pull all of that together. So again, having the right players at the table, not just the frontline workers, but all of the different layers. It's our anchor institutions like universities that Dr. Holder is affiliated with, that needs to be a part of the solution as well. So being able to work collectively and collaborate to really address with these issues is, I think, one of the big first step in getting about a solution. And so I welcome the other panelists to jump in as well.
You know, we have an example, and I've been in medicine for a while. I came in with the HIV/AIDS epidemic, and the HIV response, the Ryan White Act, was a perfect example of when we incorporated peer educators. We did all the wraparound services. They got access to care. There was housing, there was mental health services that was provided to the population that happened to be HIV infected. When you look at the data that came out of that, there was the disparities in care between Black and white was substantially reduced. The life expectancy differences were substantially reduced. So we have an existing model that demonstrates that if you provide access to healthcare, provide affordable medication, provide the wraparound services with the peer support and the peer educators and the social work system within the Ryan White program, was pretty much really what guaranteed its success. The providers were part of it, but we worked hand in hand with the peer educators and the case managers to ensure that the patients got the right care and ensure that they got proper housing, food, jobs, disability, all the services. So there's an existing model that demonstrated we could reduce disparities in care and improve the life expectancy of a population with a major disease. So if we take that model and extend it across just everybody in America, we will see the same reduction in disparities. And by address racism by ensuring through different guidelines, monitoring if the guidelines were met. So no one, and with the computer systems that we have now, you can't miss it because they were already set and the quality, and you were held accountable. So we have a model already, because you asked Santra about, is it being done? It's been done in the past with Ryan White. At FIU, we have a neighborhood health program that was social determinants, and we are very heavily supported by we call them community outreach workers, but they're community health workers.
Right.
Who really drives a lot of the connecting of our patients to all the services that they need, because you might see the provider 3-4 times a year. And models there that show them, that clearly demonstrate you must have access to healthcare, you must have the support systems, and you must have accountability and monitor how people are adhering to the proper way of doing medicine. And then that will catch your people with their biases, and that will narrow the disparities and improve life expectancy.
I do want to add some. I'm so sorry. I do want to add something to what Dr. Holder just said. You know, one of the things that keeps coming to mind is the fact that when you look at zip codes, you live in one zip code and your life expectancy is 10 years less than someone who lives in another zip code. And oftentimes it's just a street that separates. We need to get to the point where that is not happening. And I think all of what we've been talking about drives home the point, and that is a clear illustration of why we know there's differences. It is happening right before our eyes, and we need to close the gap so that is no longer the case when we keep doing these studies in the future to say why I live here and my life is worth less because I'm going to live much less, far less than my counterpart who lives one street over.
Thank you for that, Ms. Marriott. I think for me, imagine if the access to the wraparound services, Dr. Holder, I'm very familiar with Ryan White. I got my start at Ryan White as a case manager, so I always feel like many good people started at Ryan White, actually. Imagine if everyday folks had access to wraparound services where they could eat, that they had housing. Again, I don't believe we would see the disparities that we see today. And I think Ryan White is a case in point around what people need in order to be healthy. And if they do have diseases, how we work with them to really make sure that the impact and the symptoms really controlled. We have about 3 minutes. Not sure if there's I think I could take one sentence from each person, how they can find you. Definitely want to support you all. Make sure that y'all are always working and are always making sure you're sharing your knowledge and for sure Black Girl Magic with everyone. So I'm gonna start with Dr. Holder, go to Dr. Bridges, and to you, Ms. Marriott, as well.
One word, I think we just laid out everything for you here. So it's time you take this information and act. I am pushing for action for 2021 because I've seen too much death and dying. I saw it with AIDS, and now I'm seeing it again with coronavirus. But we cannot have our politicians and everyone sit back and let it happen again. We know we have the data, we know what works. We need healthcare, we need jobs, we need folks to vote like we did the last time and continue voting in local elections because policies matter. And we need to be strong enough to say when it happens and the racism and the doctors, speak up and have your advocate and call people because we're all out here, the community health workers are here. So you demand the kind of healthcare that you know you deserve. And together we can make those changes. But 2021 is for action.
Thank you so much, Dr. Holder. She's at FIU College of Medicine. If you're looking for her, looking to book her, you can do it that way as well. Dr. Bridges.
Yeah, it's hard I have so many feelings about this topic. I'm passionate about it. But I will say that I think that the failure to expand Medicaid is a demonstration of structural racism at its finest. There's no getting around it. I don't care whatever budget concerns, Florida legislators had in mind, is structural racism. And just like Stacey Abrams managed to make Georgia blue, we need to figure out a way to make Florida blue because there is no excuse for denying vulnerable people healthcare, which many countries understand as a basic human right. So I'll stop there. I'm at Berkeley Law. Look me up.
Thank you so much. Ms. Marriott, into you.
So my one word would be ditto, because I echo everything that has been said just now before I started speaking. But to add to that, I think we are going to get a chance in a few weeks with the reopening of the Affordable Care Act. And so I think this is where we need to get our community workers out to knock on doors, to be able to connect our population who needs healthcare, to be able to help them facilitate, to be able to now get this second chance that is being offered to access healthcare. And beyond that, continue to look at ways in which we can continue to integrate the community health worker as part of that care team. Because again, it makes so much more sense when you're talking to someone who understands who you are, understand your struggles, to be able to know that, okay, you have my best interest at heart. I will listen. I will make that effort a little bit more than when you feel like someone is speaking down to you, or they just don't understand, or they're ignoring you. And so we really need to be able to use the talent that we have in our community to be able to make sure that we're building a foundation for a better and healthier community. Because the more resilient our community is, it's the better for all of us. And so I'm extremely happy and proud to have been a part of this panel, to hear from all of the ladies who are here representing and are so passionate about the work they do, because the bottom line is we love our community and we want to see our community grow and thrive.
Thank you so much, Ms. Marriott. And I'll just end with this. In the wealthiest country in the world, I believe that folks should have access to healthcare, that people should have housing, that people should have jobs, that people shouldn't have to live in crammed apartments and not be able to social distance right now, right? And so again, like Dr. Bridges said, Dr. Holder, Ms. Marriott, we don't only want healthcare fairs or, fairs where we can go and get some vaccination. We want access to healthcare. We want to make sure that social determinants of health are addressed, right? We're not only talking about doctors in terms of implicit bias, we're talking about the entire system, right? And to Ms. Marriott's point, we want community health workers, folks who are like us, who are trusted messengers to help get our folks into care. And not only do we want them paid well, and we want to make sure that we see them as valuable and that their work has dignity in our communities. Please don't stop today and at this panel, but join us at the networking hour. Tomorrow we are back at 12, 5, and 6 at the Poverty Solutions Summit. Thank you all for all the questions. Please find the ladies, the panelists on all the social media networks, and I'm sure they'll get back to you all. And a huge shout out to my Catalyst Miami family. I'm super excited to have moderated this panel, and you all are phenomenal for real. I'm super excited to have been here with you all. Thank you so much.